I will introduce our next speaker, Dr. Adey. Dr. Adey is a good friend of mine. She's currently a medical director of UCSF kidney transplant program, and she is graduate. She got her nephrology training fellowship at University of Vermont and Mayo Clinic, Rochester. Then she joined UCSF, stayed as a faculty from 1996 to 2009. Then she moved to University of Vermont as a medical director of their transplant program in 2009. Then she moved back to California in 2012, joined the UC Davis transplant program, which she is a medical director. Then in 2015, she come back at UCSF. We are so thrilled for her to come back. And she's going to talk to us about transplant in the time of COVID. Welcome, Dr. Adey.
Thank you, Dr. Zhang. It's my pleasure to be able to talk to you this evening about transplant in the time of COVID. Thank you all for hanging in there as the last talk of a very long day. So I'm going to show you my disclosures. So I have a few things to disclose, none of which is pertinent to today's talk. Most of this is committee work, and very little of it has any significant amount of money and has no bearing at all on this talk. So we've got a few objectives that we're going to try and approach today. One, I want to go over the impact COVID has had on organ transplantation, describe some of the manifestations of COVID in transplant recipients, and really discuss the immunologic responses to vaccines in the transplant population. So when I was first asked to give this talk, I thought, yeah, great. I would love to talk about COVID and transplant. I live and breathe transplant, so this would be great. But then I started thinking about it, where do I begin? This is a huge topic. There's thousands of papers been published in the past 17 months about COVID. The slides were due in September, but COVID changes faster than one can keep up with. And so I knew whatever I submitted in September was going to be out of date by October 15th. So Patty graciously let me submit slides as late as last week. So that's where we are with COVID. It's a very rapidly changing field. So here's just a brief timeline of some of what was going on early on with COVID. Now, I can tell you when I was sitting in my living room in December 2019 and saw the reports coming out about COVID in Wuhan, China, I was thinking, this is going to be a problem. I've always been a little bit of an infectious disease wannabe. So I pay attention to what's going on in infectious disease and pandemics, especially given our transplant recipients are at particular risk for viral and fungal infections. And saw that and thought, this could be a problem. Told my husband, we're going to have to watch out for this. And then CIOT came 3 months later. CIOT is the cutting edge of transplantation, which is an annual meeting held typically in Arizona and by the American Society of Transplantation. And we were sitting at a board meeting. And this is right about the time you can see on this timeline when the WHO announced that this is a COVID-19 pandemic. So we're about a week before the pandemic's being announced. And all of a sudden, speakers were dropping out of the sessions and people were canceling their travel plans because their institutions were putting restrictions. So I thought, we have a real problem here. The next month, I'm in a meeting at UCSF in April, and all of a sudden there was an announcement of shelter in place. My experience with shelter in placement, there was an active shooter. Now, what do you mean shelter in place? I didn't know what this meant. So this sort of goes along with what was happening here on this timeline. First, we have hydroxychloroquine is going to save everybody. You know, it's going to be great. Then we get the announcement of this is a pandemic. There's various trials being announced. Tocilizumab is being tried. University of Washington is starting a cohort database for all solid organ transplant recipients. Remdesivir comes on the scene. So things were changing very rapidly. You can see not a month goes by when there's not at least 2 or 3 changes in the scenario. But this was leading to a myriad of questions in the transplant community. How are my patients going to do? Are they going to be at worse shape because they're immunosuppressed and they can't fight viral infections well? However, on the other hand, will the immunosuppression that they have on board quiet the potential cytokine storm that seems to be responsible for some of their severity of disease? No. So what we're finding out is the pandemic is reaching its first peak. Little did we know there'd be multiple peaks. Italy had shut down their program and were doing only 25% of the transplants they had previously done. Spain was down by 8-fold. France, the UK, the Netherlands were down 50 to 90%. And early data showed that the US was 36% decreased in the number of transplants that they were doing. So that brings up several questions. Well, what are the ethics of performing transplant, which is a relatively elective surgery? And I'll go over what is considered elective versus what is not. How safe is deceased donor procurement? Are we going to infect all of our transplant teams that are procuring organs? How safe and effective are vaccines? How do we treat our patients? So a lot of questions, more than answers, were coming up very rapidly. So the question comes up, transplant or no transplant? What do we do? Well, we had a little bit of help from the government, actually. And what I want to point out here is that very early on, the government had a memo prepared for them for members of Congress that was prepared by Jared Sussman, who is a health policy analyst. And he put this together. It's a very relatively short but very succinct memo that tried to explain to members of Congress why this is a problem for the transplant community. And one of the things I want to point out to you for people that are not really familiar with the legislative bureaucracy and regulatory nature of transplant, the organ procurement organizations and organ procurement transplantation network, OPTN, which is really run by UNOS. Most people have heard of UNOS and they know what UNOS does, which is really is responsible for allocating organs and making sure programs do what they're supposed to do. But we're very heavily regulated. And for OPOs, they have to report how many potential deceased donors were made available in any hospital at any time, what the conversion rate was to being a deceased donor, and how many organs they were able to procure from deceased donors. There's already, prior to the pandemic, been some concern that there wasn't enough deceased donors being procured. And now this was not helping us at all. So because performance is based on, our payments based on performance, it was important to explain to Congress that this was an important issue. In addition, UNOS, because it is under the auspices of Health and Human Services, they actually have the ability to submit emergency policy proposals. And on March 18th, they did put in a proposal that any program could totally inactivate the program as one blanket sweep, which is not the norm. Usually you have to inactivate one patient at a time. We could also inactivate patients without a lot of explanation of why we were inactivating patient and without all the extra documentation that was usually needed. The idea was to maintain patient safety, maintain the wait list, but without having to do all the regulatory testing that we usually have to do on a regular basis. So the purpose of this memo was to explain to Congress that we needed to relax the outcome measurements for organ procurement organizations and transplant centers during this time of COVID. So the early impact on the transplant program, as you can see, UNOS on March 18th, remember this is only a month into this, very quickly allowed programs to inactivate their entire list. And for some smaller programs, that was important. If the hospital resources were being stretched to the capacity and they couldn't get OR time, didn't have enough ventilators, there was concern for patient safety, this was an important thing to be able to do. And then the following week, there was a phased approach. So what I'm going to show you here is a series of proposals that came from an international group of transplant infectious disease doctors. Dipali Kumar is the lead author on this, and she happened to be the secretary of the AST executive committee, the board meeting that I was at that I told you about for Cutting Edge of Transplantation. She was at that meeting, as was Emily Blumberg, who was the president of AST at that time, who was also an infectious disease physician. And so this came out in March of 2020, so the same month that it's being declared a pandemic. Now, keep in mind that transplant infectious disease docs have experience with pandemics. They base their experience based on the prior HIV epidemic, SARS, MERS epidemic that we had in the, I think it was in the 1990s, I think it was in 2000, I don't remember when it was. West Nile virus, which is still a problem for us, H1N1 pandemic, Zika, which was a localized problem for certain programs, Ebola, which thank God never hit the transplant programs much. And so they know that there is a balance of risk to patients and the risk benefit of performing and postponing transplants, which is the best thing to do. There's utilization of healthcare resources that needs to be considered. So what they proposed is a stepwise progression of what should be done at what phase, depending on how impacted programs and hospitals were by the pandemic. So here I'll focus on kidney because this is a kidney meeting. A 25% reduction in transplant activity meant do mostly the elective cases. Try not to do people that were in life-threatening conditions, could be managed maybe for a little bit longer. So for kidney transplant, this is what we did. We didn't do any living donors initially. We shut down our living donor program fairly quickly because living donor will still be there, most likely, to be able to donate to the recipient. So we weren't jeopardizing the recipient's opportunity for transplant, unlike with a deceased donor, where that might be their only opportunity for months to even years. So we continued our deceased donor. We had a lot of conversation about those patients that might have delayed graft function and have a prolonged hospital stay, trying to get people in and out as quickly as possible. But we did shut down our living donor program. There was no real suggestion for other high mortality risk transplants, such as liver transplants with a high MELD, heart, lung, and SPKs. We actually shut down our kidney pancreas transplant program as well because they get a lot more immunosuppression. So then there was a proposal for what if you need to reduce your efforts by 50%? And those would be the urgent cases. Those are mostly patients who are not going to do well over the 14 days if they had to delay their surgery. So kidney transplant, they suggested that you only do highly sensitized patients because, again, these people may have been on the wait list for years, and all of a sudden, this may be their only opportunity. They may not see another kidney come their way for a year, 2 years, 3 years, or longer. Liver transplant should be limited to patients with high MELD scores. Heart, not the moderately sick patients, but the highly sick that would probably die without a transplant. So there was a very strict proposal of how this should be done. 75% reduction would be emergent cases only, and that for kidney would be people who were failing on dialysis, but were still considered a decent candidate for transplantation. We fortunately never hit the 50% or the 75% reduction at our hospital at UCSF. And then 100% reduction would be the hospital's overwhelmed. Most of the patients in the hospital have COVID, all the ventilators being used, shut down all transplant. And that fortunately didn't happen to any program that I know of in California. Well, what about the outpatient? This was a big challenge for us. Anybody that knows our program knows that we follow about 7,000 patients, and we have a lot of clinics. We typically would see 60 to 80 patients in a clinic divided amongst many providers. And we had clinics twice a week. And what do we do with this? All these people, all of a sudden, how do we follow them? We knew about telehealth. We'd done a couple of them, but hadn't been fully embraced. And so this goes through the same reduction scenarios as it did for inpatient, but this is more in the outpatient setting. So what we did is we saw all the new patients, all the transplanted patients that had been transplanted within the past month, and we went ahead and saw them pretty much once a week. If they were really stable by 3 weeks, we might let them go to video. And then we have embraced video. We were doing 75 to 80% of our outpatient follow-up as video visits. And that has continued, even though we've lightened up a little bit on our restrictions. We're still doing the early patients on face-to-face because we need to look at their wounds, need to make sure they understand their immunosuppression, which is a little harder to do with telehealth. But we reduced our clinic visits, though overall with the telehealth, our visits are up by almost 20%. Then there was the pre-transplant. What do you do with the pre-transplant patients? we kept all the REC, meaning the patients that were coming up to be transplanted by deceased donor within an anticipation within 1 year. We kept bringing those people in because we needed to be able to assess their physical capability, assess their pulses, listen to them, see how they're doing. Are they able to ambulate in a reasonable amount of time? And so we kept seeing them. Initial evals, this was a challenge. We started doing initial evaluations, which made me a little uncomfortable, but we started doing those people, seeing them by telehealth and basically getting their story and assessing whether or not they seemed to understand what was going on and putting them on the list if they seemed reasonable. I think the biggest challenge for me was living donors pre-transplant. Living donors had some of the greatest concerns about coming in. These are healthy people. They didn't want to be anywhere near a hospital. And we started seeing them by telehealth as well. But I did have concerns, and they were one of the first ones we reinstituted face-to-face visits, because over the few years, we've picked up a few problems in living donors that would not have been picked up until immediately prior to surgery if we had not seen them face-to-face, such as congenital heart disease, 2 of which had required surgery to correct their defects. So we reinstituted face-to-face visits for living donors in July of 2020, and we continue to see the vast majority of our living donors as face-to-face visits. So what were these recommendations and how was this employed across the country? So Brian Bowarski from Hopkins, who's been very active in following what's been going on with the COVID pandemic across the country, they're the first ones to put up the map to see what is going on with COVID and where were the hot spots. This was an amazing survey that he did. He reached out to 111 centers, which encompassed 87.6% of the transplants done in the US. And it was mostly transplant surgeons and a couple transplant infectious disease folks. And this was a 1-week survey. It's incredible that he got this much response in a 1-week survey. But he looked at 4 different domains. He looked at the level of transplant activity, which is what this graph shows you. He also looked at overall concern for COVID and solid organ transplantation, COVID testing availability, and the number of cases. But what I really want to show you here is, you can see in this first column, living donor kidney transplant, they really shut down. 71.8% of programs just stopped suspending their living donor program. For living donor liver transplant, a little bit dicier situation, 67.7% of their program shut down. And then for pancreas, 39.3%. So a lot of programs suspended their living donor programs with the intent that that living donor hopefully would still be available for the recipient later down the road. And on this, it's not shown on this graph, but this also showed in this paper that 98.4% of outpatient visits became restricted and they were not seeing them. So then UNOS keeps track of everything. Like I said, no field in medicine is more highly regulated and supervised and looked at than transplantation. So UNOS keeps track of what is happening with transplantation. And this graph shows up until August of this year, what happened with transplants across the board. And you can see in this first top graph, this is all comers, living donor and deceased. But if you look at the bottom 2 graphs, they divide it down by living donor transplants versus deceased donor transplants. And in the living donor transplant community, you can see that in March, when it was recommended to put the brakes on the living donor, that's what happened across the country. But in the other graph next to it, there's not nearly the amount of decrease in deceased donors. And like I said, we did not stop doing deceased donors at any point. In fact, for the calendar year of 2020, we did 414 transplants, which was a record for us. So I think some of that may have been because we got more organ offers as other programs were not taking as many transplants. That big ramp up in transplants has leveled out, and we're back now to where we were to pre-COVID numbers. So some of the limitations in being able to pursue transplant was it was getting very, very difficult to get the pre-transplant workup done. If you've got transplant patients waiting on the wait list, you've probably heard from us, we need things like cardiac caths, we need their colonoscopy to be up to date, they need to have their testing done. And we were unable to get this testing done because centers just were not open to it. The patients didn't want to go anywhere near medical facilities. We had trouble even getting the patients to get their labs done post-transplantation because not only did they not want to come to UCSF, they didn't want to go anywhere near any lab, be it LabCorp, Quest, or anything else. There were limited staff availabilities. You probably have heard there's a lot of nurses that have quit the field, and that has made some challenges. We went to a predominantly virtual setup, so a lot of our nurses are working from home. Some are working in San Diego. I've got somebody working in Washington, one in Arizona. So we've got people that are just not on site, and it has made it somewhat challenging, but also it's a lot of satisfaction for the healthcare professionals. So it's a balance. And then hospital resources were limited. There are regular meetings that have gone on about what is the OR availability? Do we have enough ventilators? Are we in trouble? Fortunately, UCSF never got into serious COVID being overwhelmed. So that's kind of where we were with this. So this next paper is, what do you do with recipients who tested positive for COVID? Some were asymptomatic, never had known disease, versus those who had prior disease, still asymptomatic, but had tested positive for COVID. And what did programs do? This was put out by David Axelrod, and he looked at 92 centers, which encompassed 40.8% of the centers in the country and 56.6% of the transplants performed in this country. And most programs, 98.8%, were declined if the patient was COVID positive. And this has been a struggle. Driving up, I'm in Fresno right now, and driving to Fresno, I got a call that trying to deal with a patient who was COVID positive, but was last sick over a month ago, and they have absolutely no symptoms, and trying to figure out what to do about that patient. So it remains a challenge of what to do with people who are COVID positive, because transplant recipients may shed virus much longer than somebody who is not immunosuppressed. So from David Axelrod's paper, it's pretty clear that people are hesitant, transplant centers are hesitant to move forward if the patients are still testing COVID positive. And to get into the hospital, you can't come in unless you get tested for COVID. So it's posing some challenges even now, 17 months into this pandemic. So what to do about deceased donors who are COVID positive? Now, this is a relatively new thing that actually got added in late. Is that safe? What if the donor had COVID, but they're fully recovered and it was a while ago? What if they died of COVID complications? Who can use these kidneys, and what are the considerations? We have to be concerned about the transplant team that goes to recover these organs. Keep in mind, when a transplant team goes out, there are several surgeons. There's often a perfusionist that's pumping the organs. And we don't want our transplant surgeons going out, picking up COVID and coming back to the transplant center to share that with us. So there's a risk of morbidity and mortality to the surgeons. There's a risk of COVID transmission to our team. What about COVID-related acute kidney injury? Should we be concerned about that? And I would say we've got to be concerned about all of it. So what has been the experience? Fortunately, CDC put out a fairly recent summary of what the experience has been. And they report 6 non-lung recipients. Lung transplant recipients are not going to get COVID positive lungs. 6 non-lung COVID recipients from 4 different donors. Another report of 38 non-lung organ transplant recipients from donors with lower respiratory tract COVID. And then this paper, which I find most interesting, is by Koval, 10 kidneys from 5 donors, all of whom were COVID positive. And this paper actually shows a scheme of what are considered risks for COVID transmission versus not. Now, in this paper of 10 patients that all received organs, kidneys, from COVID positive donors, all of these patients were transplanted with the use of induction therapy, meaning lymphocyte depleting therapy with thymoglobulin. And that is unlike the first papers that were reported where they said, we're not going to use lymphocyte depleting agents because of the risk of not being able to fight viral infections. But this 10 kidneys came out of Cleveland Clinic, and they used ATG, thymoglobulin, in all these patients, and nobody got sick. Nobody developed COVID. One patient did develop COVID antibody 1 month post transplant and had been exposed to somebody in the family with COVID prior to transplant, but had tested negative for COVID. So the good news was about this is that there was no evidence of transmission of COVID to any of these kidney transplant recipients. From other countries, there was a paper or talk I heard from, I believe it was Italy, where they did, I think, 20 liver transplants from COVID positive recipients, and not one person had become ill with any COVID from any of these organ transplants. The nice thing about the Koval paper is they looked at what are the low risk transmission. And so what they found is that if the patient had no symptoms at the time of death, no symptoms from COVID at the time of their death, that they had recovered from their COVID symptoms, that was a low risk. They also looked at imaging. If there was no pulmonary infiltrates, they were considered low risk. And the other thing that's not talked about too much is what the cycle threshold is on the PCR testing. So for those of you that pay close attention to the PCR, a lot of programs will report out what the cycle threshold is, like how many times did it have to replicate the RNA before it became positive. If the cycle threshold was greater than 30, that would suggest that it's a low viral load as opposed to a lower number, which would mean it picked up much more quickly. So we don't use cycle threshold very often, but it's something that was used in this paper, and I think it is an important point. Okay. Why am I not moving? Hold on. Okay, this next paper is from Krista Lentine, who's been very active in living donors. And this is part of another paper that I'm going to show you as well, that looked at what is the perspective on using living donor kidneys in this time of COVID. And what they found is that there is a lot of concern for donor safety. Nobody wants to hurt a donor. As one of the basic premises of kidney transplantation is living donors are giving a gift of free will with absolutely no benefit to them. The last thing you want to do is infect them in the hospital. So there's concern for donor safety. There's concern for recipient safety. There's patients' concerns. Like I mentioned before, they don't want to come into the hospital. Concerns about program outcomes. As I mentioned in the section about regulatory, if we have a high death rate, or any program has a high death rate or bad outcomes, there's concern about that being dinged and prompting a site visit or a review by the professional review board, which nobody really wants. Would we have enough personal protective equipment? Do we have enough resources? Division of time of staff to be able to do other duties, like get people worked up for transplant. Restrictions from hospital administration, and our chief of transplant meets weekly, I think still, with hospital administration to know where are we and can we continue to do transplants at the rate that we're doing. And right now we're at full capacity. So there's been some limitations. So in this paper, sorry about that. This is the prime paper that was put out that Krista Lentine was a co-author on. And what they looked at, what are the perspectives on accepting donors? And this was a 25-question questionnaire. And this went to a broad group of people. Unlike most of these other surveys that have been done, I've never seen so many surveys come out in my career prior to COVID. But during this survey, they sent this out to surgeons, nephrologists, infectious disease workers, transplant administrators, nurses, and social workers, as well as fellows, to get their perspectives on doing transplants for living donors. And they really put a broad advertisement out and put it on many of the communities of practice within the American Society of Transplantation, and got 174 respondents, which is not a lot considering the number of people in transplantation, but it did represent 115 programs. And keep in mind, there's about 190 programs in this country doing transplants. So that's a fairly decent response for a survey. And what was striking about this was the level of uncertainty, which I'll show you in this slide. The level of uncertainty about what do people do with these cases. Most of these responses were, we look at it case by case. There was not a solid confidence in what is the right thing to do. And I think this still holds true to some degree. The other question was about, when do you start working up living donors? Can you work them up within a month after COVID? Or when do you take them to surgery? So pretty consistently, that people wanted to wait 3 months after a living donor had COVID before proceeding with surgery. And some of the factors that made that decision was, did they have pulmonary infiltrates? What were their symptoms? Did they have acute kidney injury? Not all programs, understandably, were willing to take a donor that had had some AKI during their COVID illness, which I think I would be hesitant about that as well. Most centers would work them up, and then it takes time to work a patient up. You don't work them up and then go to surgery the next week. So it usually takes 2 to 3 months to get patients worked up. So there was confidence in it being able to work people up, but not confidence in when to move forward with transplantation. So what do? Our donors are all screened, and recipients are screened within 4 days of surgery. If they turn up positive, and this happens every once in a while, they turn positive, then we delay surgery by 20 days. After symptoms resolve. And we've had 2 or 3 people over the past few months turn positive, and then we delay surgery and they do fine. We seem to be seeing a lot more people who are COVID positive without symptoms over the past. Well, let's go back to what are the signs and symptoms of COVID in transplant recipients. Enver Akelin published this in New England Journal of Medicine very early on, 3 months into the pandemic. And this is more of a correspondence. It really wasn't a full-blown paper. But what was striking is the fact that fever is not that common. It's 58% of people, transplant recipients, develop fever, but that's not as high as you might think. And so cough was about 53%. Dyspnea, myalgia, diarrhea. In another paper, diarrhea was much more prevalent than any other symptom, but in his particular paper, he's out of New York, which is why they had the data to be able to present this. The most common presenting symptom was fever, though again, only 58% of recipients develop fever. So this paper from Salto Alejandre is a Spanish paper, and they looked at all the transplant programs in Spain. So there was 12 transplant programs in Spain. They looked at 210 consecutive solid organ transplant recipients that were hospitalized. They didn't look at any outpatient, but hospitalized for COVID. And what they categorized this either favorable outcome, meaning they made it discharged out of the hospital, or ICU or death is an unfavorable outcome. And what you can see in this, let's move this a little bit. What you can see is that what they found is age greater than 70 was predictive of an unfavorable outcome, which I think holds true for non-transplant recipients as well. Male gender, male sex had a less favorable outcome. And then diabetes portended a worse outcome. And as did years post-transplant. Those people being closer to transplant did not do as well. The presenting symptoms that foretold a worse outcome would be dyspnea or impaired consciousness, just barely made statistical significance. They then looked at some of the laboratory parameters of what would be portend a worse outcome. And they found that respiratory rate, this is objective, respiratory rate was a worse outcome, O2 sat less than 95%. Lymphopenia, which is not a surprise because our immunosuppressive agents specifically target lymphocytes. So lymphopenia was a portended worse outcome, as does LDH, which probably reflects lung injury, D-dimer. And then there was a question about whether or not, right on the border of whether or not developing COVID within 1 month of transplant was probably associated with a worse outcome, likely related to the impact of immunosuppression at the time of transplant. And what they found is that the mortality rate was 21.4% and the ICU admission rate 17.6%. The last slide on predictors of outcome was the TANGO trial, which is a international consortium of transplant patients, but this one is retrospective as opposed to the last one that was prospective. And this one looked at 12 centers from March to May of 2020 and looked at only hospitalized patients. This was 144 patients, but the outcomes were pretty similar. What was predictive was increased respiratory rate, increased LDH, increased IL-6. Interesting in that tocilizumab, which is an IL-6 inhibitor, had no bearing on outcomes in the drug trials early on. Elevated procalcitonin and a decreased GFR. Interestingly, there was no difference in outcome based on what type of immunosuppression the patient was on, even though our standard is to hold MMF if they get sick or mycophenolate. But in these trials, there's been no evidence that any particular immunosuppressive agent portends a worse outcome. And there was no difference based in this trial on what type of treatment they received: hydrochloroquine, tocilizumab, remdesivir, lopinavir, or darunavir. So what about mortality? Mortality in kidney transplantation is still controversial whether or not it's worse than the general population that contracts COVID. Most of the factors, again, still driven by age and frailty. And again, the early post-transplant period may portend a worse prognosis just because their immune system is pretty compromised early post-transplantation because of the higher immunosuppression. Hospitalized patient management is pretty much the same as for the general population. Early on, they may get remdesivir, steroids, may get convalescent plasma. We do standardly reduce immunosuppression, typically cutting back on the mycophenolate for mild disease, stopping it for severe disease, run lower tacrolimus levels in the barely therapeutic, the 3 to 5 range at the most. And if they're very severely ill, we'll stop it altogether. What has been coming up more recently is the treatment of COVID in the outpatient setting. And this is predominantly utilizing monoclonal antibodies. We have a program here where we will give it at UCSF for not only positive COVID, but also for post-exposure prophylaxis. That trial is ongoing. We have an emergency use authorization under, I believe, under HRSA. And as long as the monoclonal antibody supply holds up, we're still able to do this. Keeping an eye on time. One thing I do want to show you is about the COVID vaccines, and that the thought is that the COVID vaccines are good against, or the monoclonal antibodies, sorry, the monoclonal antibodies are good against all the current circulating variants. This is the current cocktail being used, and it's active against all these variants. We've had very good outcomes with patients receiving monoclonal antibodies, with very few people getting ill from their COVID if they receive timely infusion or injection of monoclonal antibodies. But lastly, I want to touch upon vaccines. It's pretty clear that there's a suboptimal response to the second dose of the vaccine in transplant recipients. There's multiple papers out that show this. But what is really striking is this one paper, or these two papers basically, that show that those patients on belatacept, 0 response in this one, and only 5.7 response. The general response seems to be more around 20%. Boyarsky, again, from Hopkins, doing a lot of these papers, but it's striking that how little response there is on belatacept. So there's been discussion about should you hold immunosuppression for the vaccines, and that is not generally advised because we don't want to precipitate a rejection episode, but it is of concern. So I think the next slide is what is a third dose versus what is a booster? In our patient populations who do not mount an adequate antibody response to 2 doses, this is not really a booster. This is a third dose, just like you get for hepatitis B. This is an additional dose of the vaccine as part of the primary series. So they don't need to wait 6 months. They get their third dose within a month of their second dose. Whereas a booster, which many of us who are not immunosuppressed will probably be getting at some point, though it's not yet been authorized by the FDA. Really strong push for pre-transplant vaccination. They're not immunosuppressed while they're only relatively maybe immunosuppressed from their uremia, but they're not nearly as immunosuppressed pre-transplant. And this shows, Miller et al. Showed that the pre-transplant population at greatest risk for mortality are the kidney transplant populations. Now, is that because of the numbers? I don't know, but if we can get kidney transplant patients, encourage them to get vaccinated pre-transplant, it's much to their advantage. So the rationale behind the third dose, there's some early data showing, this is by Hall et al., that shows that there's a nice enhancement in antibody response to the mRNA vaccines after the third dose as compared to placebo. You see it in this column and this column. And so we very strongly encourage our patients to get the third dose. I'm still fighting some patients with vaccine hesitancy, but it seems to be worthwhile to get, and they have a much more enhanced response, much less likely to be hospitalized or become severely ill. And the last point is, what about vaccine mandates? Those of you that may have Facebook accounts may see that Cleveland Clinic was prominent on Facebook because they are making vaccine mandates and refusing to transplant people who do not have COVID vaccines. This is not new. MGH just did it. I was talking to somebody today, and this is becoming more and more common. The UCSF, we have vaccine mandates in place for heart and lung. We don't have it in place yet for kidney. I don't know if we'll get there. It's as much a political issue as it is a medical issue. I would like to mandate it, but nobody made me queen of transplant yet. So we have had a couple scenarios where we're unable to discharge people from the hospital because on day of discharge, they found out that their care provider at home had just tested positive for COVID. So now we're stuck with a patient in the hospital who's perfectly ready to go home after their kidney transplant. One was a kidney, one was a liver, and we can't discharge them because they've got nowhere to go because their family member has COVID. So again, I would push for requirements for family members, donors, recipients to all get COVID vaccine. And I thank you, and I'm happy to take some questions.
Great. Thank you so much, Dr. Adey. And based on I have no authority, but I'm going to make you the queen of transplant effectively right now.
It makes my life a lot easier.
Dr. Basra has a question. When you transplant an organ, you also transplant part of an innate immune system, passenger lymphocytes. So maybe that's why the infection rate for COVID positive donor is so low in the immunosuppressed recipients.
That's one question. The other thing that I have seen is that, yes, there are RNA particles in blood and COVID can be recovered from blood, but the question of whether or not COVID in the blood or maybe in the organs, is it active and ability to replicate? And that's not clear. because it is very interesting that thus far, and we have done in the past month, we've done 3 COVID positive donors into kidney recipients, and we're testing heavily, and there's just no COVID. Maybe it is passenger lymphocytes. Maybe it's just the virus is not active.
Okay. Lisa Lane has a question. Are the donor network folks knowledgeable that previous COVID positive kidney may still be recoverable?
Yes, because what they do, what the transplant centers do is they put indicators onto what types of organs. So they will offer the organ, and it's up to the transplant center to decline. So they can make an offer. Believe me, we get offers for things that nobody would transplant because they have to make the offer. So yes, they're aware, and they're in close communication with us. So I don't think there's any concern. I think if we get comfortable doing this, we'll further increase our number of transplants.
Great. And Joanna Newman has a question. Is 20 days post-COVID is enough for recovery for donor?
That's a good question. I think for immunocompetent people, 20 days post resolution of symptoms is enough. That's a much more difficult question in recipients. I can tell you, and it's not HIPAA violation, one of our surgeons developed COVID very early on when they started closing down colleges. He went to retrieve his daughter from college in New York and picked up COVID on the flight. And he tested positive for COVID for 8 weeks. And to the best of my knowledge, he's not immunosuppressed. And he was on local news, so I don't feel bad talking about it. But the question is viral shedding, and this is not clear to me, is viral shedding as contagious after a certain period of time? Or is it just as contagious and going to increase the risk of developing more variants? So that's a good question, but I think most donors are okay by 20 days. I really can't say with confidence that's true for recipients.
Okay, great. There's no more question on the chat, but I have a question. I actually have 2. There's a talk sometimes along the way that calcineurin inhibitor may be beneficial to calm the quote cytokine storm. Then I don't heard about too much after that. Probably it's not true anymore.
Well, and that's a good question. So, early on, that was one of our thoughts. The first one was, are they going to be more at risk for picking up the virus? Because, as you know, our immunosuppressive agents very specifically target lymphocyte activity. And that's because lymphocytes are what cause rejection. So that's what we target. But at the same time, we know from experience for severe rejections that what calms down rejection is immunosuppression. And the severity with the fevers and the myalgias, when you have a very severe rejection, which is pretty rare unless somebody stops their immunosuppression, the key to that is steroids. And that really calms down the cytokine storm. I think maybe one reason why we still reduce the antiproliferatives, let the lymphocytes try and recover a little bit, but then almost all these patients are getting dexamethasone. So I think it's the dexamethasone that's probably quieting the risk for the cytokine storm. But you're absolutely right. So we actually thought maybe early on, maybe our patients won't get so sick. They'll get sick, but maybe not that horrible, fatality aspect of the disease.
Great. Last question. Now you're the queen of transplant. And how do we as a community prepare for the next pandemic? Hopefully we will not happen, but it's much better to prepare.
Yeah, no, I think what illustrates the best way to prepare is really what Dipali Kumar put together in those stages of a severity of a pandemic, and have in basically your operations manual, how do you deal with this? What are the steps so you don't have to reinvent the wheel every time? Automatically, I think decreasing living donors was the right thing to do. Because you've got options to postpone them. Isolating staff. Surprisingly, it worked really well. It's got some challenges, there's no doubt. But I think having that in almost like in your disaster plan, We have a disaster plan for other things. But I think having a disaster plan for a pandemic, I think we've learned a lot from this. And I think that should be in every transplant program's protocol.
Great. I was wrong. I said last question. I have another one if you can indulge me. What do you think about the field of xenotransplant? My personal feel is after this, xenotransplant is dead.
Well, I mean, 2 years ago, when I was still on the AST board, and we saw some great presentations from a couple of different companies that are in the field of developing xenotransplantation, looked really promising. And I thought that was probably going to lead ahead of the artificial kidney. The artificial kidneys, it's working well. It's just the logistics of how to implement it have been a challenge. Xenotransplant, the big fear, of course, are the retroviruses, and could we create more problems? And they have been genetically engineered to try and get rid of those retroviruses. But until that can be assured, the last thing we need to do is be transplanting viruses into immunosuppressed people. And that's been the biggest challenge. I mean, porcine kidneys, pig farms would be great. We wouldn't have a kidney shortage if we could make that work.
Yeah, but the virus really.
Yeah, viruses should scare you.
Yeah. All right, I was told the last question, please. So thank you so much. Sorry, Benedict. I will forward your question to Dr. Adey. We can talk outside of this. Really enjoy your talks. Thank you.